Back again. I've renamed the video title at least. Okay, actually, I wasn't willing to do anything at all, but then I actually means to just edit the video and things like that. But at least I edited the title because I was able to do that from the OBS, this thing that I have here. Okay, so now let's go to this page. Okay, this is 509. Okay, so let's start off. Now, this is very important because we'll just go through the numbers. Okay, let's see first, this is the resting minus 75. Main cheese, this is neuron action potential. Okay, neuron action potential, that is important. Potassium ka this thing and this. Okay, these two have these two has come actually. Okay, especially this, this potassium ka correlation. Okay, so that is important. Now let's go. First is resting potential is minus 75. Okay, and you have this the sodium, it basically first we have a local EPSP, and then after that we have a fast sodium channels opening. So first one is what? Resting membrane more permeable to potassium than sodium at rest. Okay, obviously. Okay, that's why you have leaky potassium channels and all that, and voltage gated sodium potassium channels are closed in this resting membrane potential. Okay, next what do we have is membrane depolarization. Okay, so membrane depolarization two, this one. Okay, the peak. Okay, so that is your peak. Okay, so you slowly have the peak, and there you have what? Obviously fast sodium channel. So fast. Okay, the word fast is important. And obviously another thing is that initially they have some sort of a EPSP, local EPSP. Okay, at minus 55. Okay, and then the threshold potential is reached at the initial segment, and this is a form of positive feedback. Okay, so this is important, that it's a form of positive feedback. Okay, this EPSP to threshold potential. Okay, you basically have means one sodium channel opens because it becomes more positive. Okay, inside, so that's why more sodium channels start opening. Okay, so it is this entire process is a positive feedback. Okay, this is orange, so basically taken from Zainab ma'am's stuff, and this. Okay, so initial segment positive. Okay, next is phase, slowly it reaches peaks. Okay, so that is 2. Next you start with 3. 3 is basically memory deposit, obviously. Okay, sodium this thing. Okay, sodium trans closes. Now main thing is, this thing is very important, these correlations. Okay, so first what happens, voltage gated sodium channel, the entry pore is 0.1 milliseconds, it opens for 0.1 milliseconds. Okay, alpha subunit, alpha, remember alpha subunit. Okay, alpha subunit of the sodium channel that is doing all the opening and closing. So first thing, okay, number 1, okay, your activation gate is closed. This is activation gate. Okay, and this is inactivation gate. This niche wala is inactivation, this is C, this is your activation gate, and this is inactivation gate. Okay, this particular, this line is inactivation gate. Okay, so activation gate is closed here. Okay, then after that, then suddenly these two, this is the activation gate, this part. Okay, so activation gate opens, and when activation gate opens, this upstroke is due to activation gate opening. Okay, that is most important, activation gate opening. Okay, that is giving you the fast sodium channel upstroke. Okay, now this lowering. Okay, when this starts going down during this period. Okay, when it starts going towards the when the potential starts coming down, that time you basically have the inactivation gate is closing. Okay, so initially what happens, activation gate opens, and because of that you have the fast upstroke, and when the inactivation gate closes here, then you have the downward motion. Okay, when you have the potassium being potassium getting out, that time the inactivated. Okay, it is inactivated, remember. Okay, so here it is activation gate closed, here it is a phenomenon where it is open, everything is open, activation gate is open. Okay, this particular, this thing is activation gate. Okay, and this tail here is the inactivation gate. So here number 3, inactivation gate is closing. Okay, and then finally, in case of resting state, what happens, resting state, your inactivation gate is open, but activation gate is closed. Okay, so this thing you remember. Okay, in the downstroke, inactivation gate, in the resting state is activation gate is closed. Okay, so yeah, that is important. Okay, next we have maximum is how much, maximum is plus, maximum peak that it can reach is plus 63.5, which is basically the electronic potential for sodium, that is the peak. Okay, plus 63 millivolts. Okay, and here the another peak, this is the maximum peak is basically of this sodium, okay, the maximum peak. And here another very important this thing is it goes till your plus 30 to plus 35, basically 40 till 40, okay. So yeah, I think more or less that is clear. Okay, so that's what they're saying here. And the third is basically the sodium inactivation goes gate closes, okay, and because of that this thing, okay. And here in hyperpolarization, obviously the gates are slow to close, so that's why there's excess efflux and all that is simple. Okay, next see this, okay, potassium and sodium ka permeability is very important here. Okay, potassium and sodium ka conductance, okay. So basically what happens is the peak upstroke of the sodium relativity, okay, upstroke of the sodium, that basically coincides with the membrane potential upstroke, okay. And when the membrane potential is coming down, it basically coincides with potassium permeability that increases, okay. So that is important. Next is this downstroke will coincide with the potassium increasing. Next is another thing, see this upstroke, okay, this upstroke, suppose if they ask, I think they've asked also somewhere else, I mean, this is I think pink, anyways, whatever, this is nice to know that, you know, when this upstroke increases, then your it is tetrodotoxin. In case of tetrodotoxin, okay, when you have tetrodotoxin, then you have no action potential. I think this is USMLE ka, okay. It is USMLE, okay. Tetrodotoxin, there's no action potential. When this increases, okay, so tetrodotoxin, there'll be no action potential only, okay, in the presence of tetrodotoxin, okay. And obviously sodium conductance, all this is fine, okay. Your potassium, okay, here it is maximum. When is the potassium permeability maximum? It is in mid repolarization, okay, mid repolarization, okay. While it is coming down this action potential ka curve, potassium permeability is maximum in the mid repolarization phase, okay. and and your tetraethyl NH4, it slows the repolarization, okay. So leaky sodium channel, basically it increases the action potential duration, so maybe it will go like this something, okay. So that is not very this thing. There's a tetrodotoxin is a bit important, okay. And this thing, so all this is fine, okay. And yeah, actually this part, okay, this open and inactivated, when it's inactivated open, this had come in INI, okay. And this had actually, this can come as a rearranged question also, match the following question also. So yeah, open and inactivated gate when it's closing, then you have the downstroke, and here resting may you basically have the activation gate closing, and then you have inactivation gate opening. Next is this. Now, here I'll also correlate one more thing, and that is basically Zaina ma'am has taught this very well. Okay, to be very honest. Okay, just this thing is important, that the one that we had was means the one that usually gets people get mixed up with it also. That is Merkel's. Okay, so Pixarize actually has a very good this thing for this. Okay, so just wait a second. Okay, so this basically I had it in MER. This is in one of the MERs. Okay, so what happens is when you have tactile receptors. See, these are pixelized images. Okay, it is very nice. I mean, you can just go through it. Okay, location and position sense and Meissner's corpuses and stuff. Okay, but then I can get a copyright, so I'll just maximize this a bit. Okay, see, tactile receptors. Okay, it is divided into the rapidly acting and slow adapting. Okay, so when ma'am had given this mnemonic that Miss Pacman Meissner's, okay, so Meissner's Paxinian, okay, Meissner's is basically Meissner's and Paxinian is your rapidly adapting, while Merkel and Ruffini's is Mr. Miss Pacman is rapid, okay, so it gets excited, she gets excited, she gets goosebumps, I paint Pacman and so on. All this was this thing, okay, and only epidermal fibers when you have. Okay, so this is Merkel is the only epidermal fiber that you have, and Paxinian may you had deep pressure, and you also had this thing. You had deep pressure and you also had vibration sense and all in Paxinian, and there was also muscle. These are all onion skin appearance and so on, and it is very fast adapting and so on. Okay, next is rapidly adapting. Okay, so rapidly adapting is basically Meissner's and Paxinian. Okay, next is slow adapting Merkel Ruffini nerve endings type C fibers. All right, and yeah, I think this should be more than enough. And this thing, okay, next is the main thing is the Erlanger Glasser classification is also very important. Okay, these are exercise stuff. Okay, so I'll get copyright. Okay, mainly when I'll just remove this video, then this thing. And this was a stretch receptor. Stretch receptor was Ruffini's. Okay, so Ruffini's ending is going to be the skin stretch receptor pressure in the joint cap and so on. Okay, and next is this thing was the MAMCA type C fibers is all the pain and everything and tickle and nociception and so on. Okay, so this is not very this thing, like this is a better table that basically ma'am had, that Meissner is fast obviously all this, and this is going to be slow. Okay, Merkel, Ruffini, free nerve endings and so on. So Meissner is basically most numerous non-hairy fast touch, and this side is largest onion shaped and maximum sensory increased vibration sense is Paxinian, like I had said, and hair on end organs is obviously Hammer, and this Merkel is going to be Braille. Okay, so this is very important. Merkel is the one that is 2 point discrimination. Okay, this is the one that there keeps on a confusion keeps on happening with this. So Merkel is the 2 point discrimination. Okay, Merkel is the 2 point discrimination. Merkel is the 2 point discrimination. Ruffini is joint perception. All that is fine. Okay, Merkel is the 2 point discrimination. This remember, Merkel is 2 point discrimination. Merkel is 2 point discrimination. Okay, so Merkel is 2 point discrimination. Alright, and Merkel is the one. Basically, Merkel is Braille. Okay, basically we used to say no Prof MB. I remember in Calcutta we used to say MB. So MB Merkel. Okay, next you have is these are the few receptors, so you can just go through it also, but just let's go through this one first. Okay, next is polymodal receptors or nociceptors. Okay, so in that obviously free nerve endings. Okay, so free nerve endings you had A delta fibers, and A delta fibers were the myelinated ones. Okay, so they were fast. Okay, because they were A delta, and slow was the C fibers, that was unmyelinated. So A delta fibers fast, this is a bit hi-fi or more hi-fi, that is going to be glutamate. Okay, and slow is going to be C fiber, that's going to be substance P. So it's going to be deep-seated visceral pain. Okay, and this is going to be slow pain, tickle, itching and so on. Okay, those are the free nerve endings and so on. So fast, okay, Delta Airlines and this thing. Okay, that's what ma'am had to say, and this is taxi, it is slow, but then it is very simple. I mean, obviously slow fibers will always be unmyelinated, and substance P is like, it feels like a very this thing, very primitive kind of this thing. Now this table is actually was very this thing, so let's quickly so Lloyd Hunt. Okay, this one was 1A was supposed to be proprioception and somatic motor. Okay, 1A 1B was proprioception, and this is important for that local anesthetic toxicity and all that also. So 7 to 20, 70 to 20, 120, that is important. Okay, 2 was going to be touch, pressure, vibration, fine sense. Okay, 30 to 70. Gamma, okay, is gamma is going to be muscle spindle. Okay, muscle spindle delta is going to be fast pain, crude touch, temperature. Okay, fast pain was delta, slow pain was type C. Okay, your this thing. Okay, preganglionic autonomic is important. Now this particular this thing, this table is was one of the questions in JIPMER and all also. Okay, so postganglionic. Okay, postganglionic sympathetic, preganglionic sympathetic. Okay, this is fast. This thing crude. Okay, efferent muscle spindle for Hulk and this. Okay, so Lloyd Hunt classification. The ma'am had given very nice mnemonic about the alpha male and deep pressure. Okay, when you want to do massage and muscle spindle, Hulk was exposed to gamma waves and so on, and touch temperature and cold sensation is delta. Okay, so that is it. Okay, crude and slow. Okay, next just this thing. So see, the lower ones, basically A ka lower ones, that is gamma and delta. Okay, so gamma and delta is first in case of local anesthetic, and alpha and beta is in between, and B and C is afterwards. Okay, so B and C is last. Okay, alpha and A beta is in between, and A gamma and A delta is front में. Okay, next is pressure. Oh, okay, warm burning sensation, this is okay. Cold sensation is A delta, that is also fine. Pressure is ABC. Okay, so pressure is ABC, first A and then after ABC, the sensitivity, and hypoxia is this thing. This is descending order of local anesthetic sensitivity. Okay, so that means these are the most sensitive. Then after it, A alpha and this thing. They had asked one question saying that like this had come in one of the central institutes only, that which fibers, okay, means which sensation or which kind of sensory property is the first to go. So that is also very this thing. Okay, so it was like A delta was in the option and so on. Okay, so it was the answer was temperature and this cold sensation. Okay, so next is hypoxia is BAC. Okay, so no है भागो, ठीक है, that was the mnemonic basically. Okay, so yeah, so I think this much is fine. Okay, yeah, I mean this is like this is like done kind of. Okay, so most important is that table. Okay, so this table is very important. Okay, so this table is very important, and we have the table and fibers and so on. Okay, so this table, vibration beta. Okay, beta is vibration. Okay, proprioception alpha. Okay, and muscle spindle is gamma. Gamma wave muscle spindle. Okay, with delta obviously. Okay, okay, next is what do we have? All this is done. Okay, and this one or Gabris and all that, this is very good, well given and pixelized, this entire thing. The most important thing is deep static touch, that is the okay. Okay, and this is myelinated, adapts very slowly. Okay, so Paxinian and Meisner were the faster adapting ones, while Lupini and Merkel were this thing. Miss Pacman. Okay, Miss Pacman was faster. Okay, and another very this thing was that yeah, the braille thing. Okay, Merkel is important for the braille part also. Okay, so braille this thing. Okay, so Merkel was also important for braille. Okay, so braille 2 point discriminant epidermal edge, Merkel. Okay, so that is done. Next is another free nerve ending. Free nerve ending is present in all tissues except cartilage, islands, and skin. Okay, so this is very important. Except cartilage, island, skin. Cartilage, island, skin. Okay, in this free nerve endings are not present. Okay, except cartilage, island, skin. Cartilage, island, skin. Okay, cartilage, island, skin. It is not present in cartilage, island, skin. Okay, again we have GB syndrome. So GB syndrome was what? Schwann cells. Okay, GB syndrome was Schwann cells. Okay, Schwann cell issue. Okay, so endo the and very important, some barrier will come. Okay, so blood this thing barrier. Okay, so that is also important in this. Okay, that barrier thing. Come on, let's do it faster. Endo near thin supportive. Endoneurium is whatever ensheathes the nerve fibers, individual nerve fibers, okay, individual myelinated nerve fibers, and endoneurium is the one that is specifically affected in GP syndrome, okay, and perineurium, okay, not sure this thing. We had oligodendrocytes, and yeah, okay, so this is mainly this Guillain-Barré syndrome is endoneurium, okay. Perineurium is blood nerve permeability barrier. This is important, okay. This is see, there'll be some things that I actually did questions for and I came across. So this perineurium had come in JIPMER, okay. Blood nerve barrier who forms, okay. So blood nerve barrier permeability is formed by perineum, okay. So perineum surrounds the vessel, and epineum, okay, this is dense cartilage surrounds the entire this thing with blood and vessels. Everything is inside the epineum, okay. So everything inside the epineum, so that's it, that is going to be surrounding everything, okay. And perineum is going to be blood nerve and permeability barrier. Done, okay. Blood nerve permeability barrier is going to be perineum, okay. So and that GBS is going to be peripheral nerve. GBS is going to be endoneum, that is important. GBS, endoneum, perineum, blood nerve powder. Bus. Okay. I keep on spending too much of time, so that's why we have to go more quickly. Okay. Next is chromatolysis. Chromatolysis. This is important. Chromatolysis. They had one. They had one question on this. Okay. Actually, every paragraph it's like there's one or the other question. So increased protein synthesis. Okay. So what happens? Just quickly, just let's read through this entire this. The reaction of neuronal cell body to axonal injury. Obvious, hai? Okay, axonal injury. How will the neuronal cell body react? Okay, there increased protein in effort to repeat the obviously. Okay, increased protein synthesis is going to be the round cellular swelling. Okay. Now, in case of reversible cell injury, you do have cell swelling, okay, displacement of nucleus to the periphery, okay, NC ratio also this thing. Just try to recollect that part from general, okay. General may you have those two charts where you have irreversible and reversible cell injury. So this is something like that: round cell swelling, displacement of nucleus to the periphery, dispersion of nucleus throughout the cytoplasm. What is volume degeneration? It is disintegration of the axon and the myelin sheet distal to the site of the axonal injury, and it is removed by macrophages. Okay, so distal to obviously the site of injury, you basically have here you have the site of damage, and distal to this basically you have volume degeneration. Proximal to the injury, what happens? Axon is going to retract. Okay, that's what axon is doing here, retracting, and the cell body starts spouting new protrusions that grow towards the other new for potential innervation. So this is a preparation for axon degeneration and functional recovery. Okay, so here only everything is mentioned that you're getting cell swelling, you're getting displacement of nucleus to the periphery, you're getting dispersion of the nasal cells, chromatolysis also you're getting chromatolysis. It's happening here. This entire process is chromatolysis, and axonal retraction happens proximal, and volume degeneration happens distal. Okay, here you have microglia infiltration. Obviously microglia is derived from mesoderm. Okay, these are resident macrophages. Okay, and then finally, and what was this thing? Synaptophysin was for oligodendron. Okay, and then you basically have myelin debris. Okay, so next is this. Okay, now this you can see how the chart is like completely colored. Okay, so this is has come quite a number of time, Huntington's disease and this thing. Okay, so the basic thing, okay, first acetylcholine, basal nucleus of Maynard, okay, that is forebrain. Alright, we'll just give it a reading. इसको बाद में we have to revise. Okay, again. So basal nucleus of Maynard, actually not really. Okay, so you have anxiety, depression, schizo, Alzheimer, Huntington's and Parkinson's disease. Okay, now what happens is depression, everything is depressed. Okay, so everything is depressed in depression. Okay, anxiety, what happens? Okay, anxiety, what happens in anxiety? Only this is increased, your norepinephrine. Obviously when you're anxious, then your sympathetic system is like in a crazy this thing. Okay, so that time locus coeruleus, that is present in the pons. So locus coeruleus present in the pons. Okay, that produces your norepinephrine, that is increased. Okay, next is anxiety increased. Okay, your norepinephrine. Depression, everything is low. Okay, and schizo mein what happens is, schizo, this is one point of contention. See, everything is low in schizo. Okay, everything is low in schizo. Okay, just remember schizo rhymes with low. Everything is low except serotonin. Okay, now think of it in this way also. SSRI. Okay, when we had SSRI, the selective serotonin reuptake inhibitors. Okay, so whenever you have serotonin, okay, like there's this kind of sexual apathy and libido lost and all that. So schizophrenia may also that. Okay, so this kind of behaving like SSRI schizophrenia. Okay, so serotonin is high. Okay, in case of this, serotonin is high. Baki everything is low. Okay, now this is also low. Okay, acetylcholine. Now the most important this thing is this particular this thing in this. Okay, what happens is dopamine, subcortical dopamine is raised, but prefrontal dopamine is decreased. Okay, so this is very important. Subcortical dopamine is increased, but prefrontal dopamine is decreased in case of schizophrenia. Okay, so schizophrenia subcortical dopamine increased, but prefrontal dopamine decreased. Okay, so iske mati brushed. Okay, whatever. Okay, next is Alzheimer's. All is the case. That's why you have because this is obviously Alzheimer may, because this is low. Okay, this had come as a question and it always comes donepezil, rivastigmine, and all that. Okay, so galantamine also. Okay, so this is because this is decreased. Okay, acetylcholine inhibitor, then you have treatment. Okay, that forms the treatment. Acetylcholine esterase inhibitor, because it increases the amount of acetylcholine and therefore it helps in Alzheimer's. Okay, another thing. Okay, actually let's correlate it here only. Okay, see, in Alzheimer's disease you have two this thing. You have two monoclonal antibodies. One is adalimumab. Okay, and another one is no, not adalimumab, adacanumab. Okay, aducanumab. Okay, and another one that you had was, what was it? Okay, one more was there. Lecanemab. Okay, something lecanemab. Okay, the mnemonic is basically a Bengali mnemonic. Okay, so when Alzheimer's will come, then maybe yes, I'll tell you the mnemonic. Okay, for this. So Huntington's disease is a Bengali mnemonic, but okay. So Huntington's disease is decreased. In this, everything is decreased except this. Dopamine is increased. Okay, so Huntington has come in NEET PG. Okay, and Parkinsonism, obviously dopamine is decreased in Parkinsonism. Basically this is increased. Acetylcholine is decreased. Okay, all this you don't have to look at this. Okay, so here acetylcholine is increased and acetylcholine is increased here. Okay, acetylcholine is increased in this. This is the only place where acetylcholine increases. Rest see all acetylcholine decreasing. And who is secreting acetylcholine? There is a basal nucleus of MENAT. Actually, there's no use of coming back to this. Depression, everything is going to decrease. You all know that. Anxiety may obviously norepinephrine going to increase. That is locus coeruleus. GABA is coming from the nucleus accumbens. In fact, this nucleus is something that needs to be remembered. Raphe magnus nucleus, your this thing, brainstem. Okay, that is present in serotonin. And serotonin is the only thing that is increasing in schizo. Okay, so and this point of difference is important in case of schizo. Mati brushed. Okay, that's why it's increasing. I mean, that's why this is decreasing. Basically, mati brushed, the prefrontal cortex is decreasing dopamine, and here your serotonin, this is increasing. Okay, and in case of Huntington's chorea, the only important thing is dopamine is increasing. So basically, schizo and Huntington's chorea, दोनों में dopamine is increasing to some extent. Here subcortical and here in Huntington's chorea. Okay, here prefrontal mein it is decreasing, kind of like mati brush, whatever. Okay, and in case of Parkinsonism, obviously dopamine is decreasing and your acetylcholine is increasing. So I think just this, that's it, and I can literally remove it from my outline. This is one of the things that is there in my outline. So yeah, so next when we do outline, then we'll just do this, and we'll do this point and this point this particular point, this point, this point, and this point, and this point. Okay, and this is important. Okay, I equal one more thing. Yeah, dopamine is tegmentum. Okay, dopamine is fine, dopamine is okay. The main is this: basal nucleus of MENAT secretes acetylcholine. Nucleus accumbens secretes GABA. Okay, locus coeruleus, norepinephrine, raphe is serotonin. Okay, so this is okay. Next, come to this. Okay, this thing. Okay, so CSF, arachnoid space, all this is okay. And epidural space is this thing, potential space within the dura mater and the skull, that is the vertebral column that is connecting. Site of blood collection, okay, also the middle meningeal artery, that's the epidural space. Fine. Okay, next is this is important. Areas devoid of pain fibers is going to be bed pack. Okay, so this is a mnemonic that I had made sometime. Bed pack. Okay, so brain parenchyma, ependyma, dura mater. Okay, pia, arachnoid, choroid, plexus. Okay, so dura mater is not covering the blood vessels, not contributing to the dural venous sinus. Okay, dura mater that is not covering the, so this is a catch. Dura mater that is not covering the blood vessels, or that is not contributing to the dural venous sinuses. Okay, so dura mater that is not covering the blood vessels, or it is not contributing to the dural venous sinuses. Those are the ones that are basically going to be devoid of pain. Brain parenchyma is also devoid of pain. Pia mater is devoid of pain. Arachnoid is devoid of pain. Choroid plexus is devoid of pain. Ependyma. Bed pack. So brain parenchyma, ependyma, dura mater that does not cover the blood surfaces and dural venous sinuses. P is going to be pia mater. A is going to be P is going to pia. A is arachnoid. C is choroid plexus. Okay, so this is done. Next we have blood brain barrier. Okay, so blood brain barrier is important. Okay, so the blood brain barrier. Okay, so here this is very important. You can see so many purples. Okay, so it has come a number of times. Okay, so blood brain barrier. Okay, the first thing, tight junction, obviously. What is the zona occludens? Okay, basement membrane. So zona occludens, you have basement membrane, capillary endothelium. Okay, you have soap. Okay, so the mnemonic for this is soap. The soap is sub for nasal organ. OVLT. A is area postrema, and P is what? P is posterior pituitary neurohypophysis. Okay, posterior pituitary neurohypophysis, median eminence. Just a second. Just a second. Okay, so let's go back to this quickly. Okay, so area postrema is done. Okay, neurohypophysis, basically there's the median eminence. So median eminence, you get all the substances from the pineal gland. Now that, anyways. Okay, so first thing, all this is fine. It's formed by four structures. What are the four structures? Tight junction, non-fenestrated. Okay, kidney mein we had fenestrated, so this is non-fenestrated capillary endothelium. Okay, non-fenestrated, remember this, tight junction, it is tight junction, zona occludens. So non-fenestrated capillary endothelial cells. Okay, remember the kidney. Okay, and think about that, and it's something like that only. So non-fenestrated capillary endothelial cells, basement membrane, and astrocyte ka food processes, and pericytes. Okay, so what all do we again, let's go back and see this. Okay, let's look at this nicely. Okay, so that we don't have to come back. I mean, this is like rapid. Okay, iske baad we are not going to see it again. Okay, so capillary lumen done. Okay, so capillary lumen, all this. Okay, then we had basement membrane. So this was supposed to be that non-fenestrated capillary endothelial cells. Then we have basement membrane. Okay. Then we had these food processes, the astrocytes. Food process, the astrocytes, and then we have pericytes. Okay. Next, the components is very important. Glucose and glucose amino acids. Okay, they're carrier obviously, and non-lipid soluble that will cross. Okay, so lipid soluble. Name one drug. Physostigmine. Physostigmine cannot cross. Okay, cannot cross. Atropine crosses and stuff. Okay, next is neostigmine. Okay, next is circumventricular organs. Okay, with fenestrated capillaries and no blood-brain barrier. Okay, so blood-brain barrier we saw what were the this thing. Okay, ki you have fenestrated capillaries, you have, then you have the basement membrane. First fenestrated, non-fenestrated capillary, non-fenestrated. Okay, non-fenestrated basement membrane, astrocyte food process, pericytes. Okay, so we have all this. Next is circumventricular organ, fenestrated, no blood-brain barrier. Okay, we had soap. Okay, soap was the mnemonic. Okay, OVLT was the area postrema and all that. Okay, soap was subfoveal organ, OVLT, area postrema and posterior pituitary. Okay, and here you can read out this also. Area postrema, vomiting after chemotherapy. Okay, vomiting after chemotherapy is due to area postrema. OVLT stands for organum vasculosum lamina terminalis. These are osmoreceptors, centrally acting osmoreceptors, and most importantly ADH. Okay, so or neurosecure this ADH release. Okay, this involved in ADH release. Organum vasculosum lamina terminalis osmoreceptors. Organum vasculosum lamina terminalis osmoreceptors. Next is this is what I have put a question mark here. Infarction and or neoplasm destroys the endothelium, so that's why you have vasogenic edema. Fine. Okay, endothelial tight junctions, if it this thing, then obviously there'll be movement of water and all. Okay, and hyperosmolar agents like mannitol can disrupt the blood-brain barrier and increase the permeability of medication. So this is also something to be noted. Okay, mannitol can disrupt the BBB. Okay, that is the BBB. Next is this. Okay, so this you don't have to concentrate on this part. Okay, actually this Zainab ma'am had a very good flow chart, but I haven't read that part. Anyways, whatever. Nucleus tractus oritalis in the medulla is the one. It really receives this thing from the chemoreceptor trigger zone. Okay, located. So nucleus tractus oritalis medulla receives information chemoreceptor trigger zone, located in the, where is the chemoreceptor trigger zone? It is the area postrema. Okay, in the fourth ventricle. Where is this area postrema located? Okay, after chemotherapy. So it is in the fourth ventricle. That is the closest to lower this thing. So jaldi jaldi aaya. Next is GI tract. Why GI tract? Vestibular system and CNS. Okay. So CTZ, that is chemoreceptor trigger zone, adjacent to the worm receives input from 5 major centers. Okay, CTZ and adjacent this thing, adjacent vomiting center. It receives from muscarinic, dopamine D2, okay, histamine H1, 5-HT3, okay, and neurokinin NK1. One very important thing about NK 5-HT3 is I think all the other 5-HT3 is this thing. Only this is supposed to be ionic or something. Okay, anyways, whatever. 5-HT3, so these are all inputs that are coming. Okay, so M1, D2, H1, 5-HT3, NK1. M1, D2, H1, 5-HT3, NK1. These are all the inputs. Okay, so 5-HT3, D2, NK1, they are used to treat chemotherapy induced vomiting, and H1 and M1 is obviously used for treating this thing, motion sickness, and H1 is hyperemesis gravidarum. Okay, so D2 receptor blocker, we have our all those ondansetron and so on. Okay, so and H1 and M1 we had, M1 was hyoscine, okay, scopolamine and so on, and there was one this thing from one H1 receptor promethazine. Okay, so all that we got that. Okay, next is, okay, so there's some anatomical parts that this is not like very important. I just stretched it up too much, kind of. Arachnoid villi, the structure of arachnoid villi, subarachnoid spaces and cisterns and canals, it's not that important. Like CSF ka flow little bit you can see. Okay, that but then this is not that this thing. Sylvian sulcus, middle cerebral artery is in the Sylvian system. Okay. And here what do we have? Interpeduncular, yeah, just the nerve, छोटा सा blood supply. Sylvian cistern में we have middle cerebral artery, and interpedunculaar cistern में we have the PC and the posterior communicating artery. Okay, you have cerebellar peduncles, you have midbrain here, and yeah, that is that. Okay, so that is done. Next is sleep. Okay, so basically sleep there's a mer also. Okay, so it's good to revise that as well. Okay, because ma'am has a lot of mnemonics in that. Okay, so one sleep cycle is 90 to 120 minutes. Okay, so one sleep cycle 19 to 120 minutes. Sleep physiology. Okay, suprachiasmatic nucleus, circadian rhythm, circadian nocturne release of this. Okay, ACTH, prolactin, melatonin, norepinephrine. Okay, what all is it secreting? ACTH, prolactin. Okay, controls the nocturnal release of what? ACTH, prolactin, melatonin, and norepinephrine. Okay, so SCN. Okay, suprachiasmatic nucleus, norepinephrine release. Okay, and pineal gland increases the melatonin. This actually has a very good this thing. You know, all the hypothalamic nucleus, and there's a good table. I mean, there's a good picturized picture also on this, कि norepinephrine, pineal gland increasing the amount of melatonin, so that's why we can go off to sleep. And SCN regulated by light. Okay, two stages, this we know. Next is which one decreases the REM sleep. Okay, so alcohol, benzodiazepine, barbiturates. Okay, BAB. Okay, these three they decrease REM sleep. This is also in one of my outlines. Okay, important topic. Okay, so alcohol, benzodiazepines, barbiturates, they decrease REM. Okay, and N3. Okay, and here norepinephrine decreases REM, and benzodiazepines are useful for nighttime sleepwalking by decreasing N3 and REM. Okay, next another very important. Alcohol is bad. Benzodiazepine is used as a curative treatment to deal with night terrors. Okay, so now we come to the table of sleep. Okay, so first we have what? Awake, eyes open. All right. Okay, sleep state person done. Okay, so eyes open 1340. Here we have mainly beta. Okay, bats drink blood. Okay, that was the mnemonic. Okay, so BAT, bats drink blood. We have alert, active mental concentration. Beta has highest frequency, lowest amplitude. Highest frequency, lowest amplitude. Obviously the eyes move, keep on moving, so basically highest frequency. Okay, so highest frequency, lowest amplitude. And yeah, the actually all these waveforms, there's ma'am has a class on sleep. Okay, so do look at the waveforms from there as well. Okay, so frontal, okay, means which part of the brain is active. Okay, in each of this. Okay, next is relaxed wakefulness. This phase is called relaxed wakefulness. That is alpha. Okay, alpha, it has alpha this thing. Okay, there's change in response to beta stimuli. Okay, next another this thing. Okay, when eyes are awake. Okay, when you have eyes open, EEG is fast, EOG is positive, and EMG is also positive. Okay, there's there's this thing, there's electrical activity in all of this. Okay, in case of awake with eyes open. All right, yeah, next is you have eyes closed, that is alpha. Okay, next is non-REM. So N1, N2, N3, and REM. Now main thing is what is the wave and what is found. Okay, and what kind of pattern you'll see, and what is the characteristic feature. Okay, so that is the main this thing. So light sleep, muscle jerks, N1. Mixed frequency vortex, theta. Okay, so theta. All right, muscle jerks. All right, parieto-temporal, that was parieto-occipital. Frontal, parieto-occipital, this is parieto-temporal. Temporal and muscle jerks, theta. Mixed frequency vortex wave. N2, deeper sleep. Okay, so okay, N2 is deeper in bruxism. This is important. Bruxism, N2, sleeve spindle, K complex. Okay, sigma. Sleeve spindle, K complex, sleeve spindle, K complex. N2 has all bruxism, sleeve spindle, K complex. Even the muscle jerks thing is not important. N2 is very important. N2 is bruxism, sleeve spindle, K complex. Okay. N2 is K complex, okay, occasional biphasic wave, high voltage waves, okay, and sleep spindle is sinusoidal waves, okay, sinusoidal waves 12 to 14, okay. So deep sleep, bruxism, sleep spindle, K complex, bruxism, sleep spindle, K complex, bruxism, sleep spindle, K complex. N3, sleepwalking, night terrors, bedwetting, okay. P flea in N3, okay. So this is delta wave, deepest stage of sleep, okay. So that was the highest frequency, this was highest frequency, this is lowest frequency. B, D, okay, looks like similar letters, so just the opposite, okay. Lowest frequency, highest amplitude. Alright, next is N3, sleepwalking, night rest, bedwetting. Sleepwalking, night rest, bedwetting, delta, deepest sleep. D for delta, D for deepest sleep. Okay, N3. और ये mnemonic is very important. B, P, flea, P is bedwetting, flea is night terror, terror में आए, if we are in terror then we start running, and then N3. Again delta is deepest sleep, okay, delta is deep. Next is REM sleep is loss of motor tone, okay. REM sleep में you're not a nightmares, the terror, when you are in terror then you start running, okay, so that is an N3, okay. Remember the mnemonic, P, flea, N3, okay. 2 में bruxism, so tooth, okay, tooth, basically tooth 2, alright. Sleep spindle, K complexes, that is with this thing, okay. And here you are sleepwalking, night is bedwetting, okay. And here REM, loss of motor tone, nightmares, peniloclateral tumescence, okay. Everything else extraocular movement, okay. See, in these two you'll find extraocular, none of the other N stages you'll find extraocular movement, okay. REM or non-REM, okay. Extraocular movement will be then awake, but here you'll find extraocular movement, that is in REM. REM there will be extraocular movement, so this is important. REM में extraocular movement you'll see, okay. So extraocular movement is important due to PPRI, that is pyramidal pontine reticular formation, conjugate gaze center, okay. Occurs every 90 minutes, duration increases throughout the night, okay. So this is important, and then there are the changes, alright. So first we'll just look at this, okay. How is this REM sleep ka picture? Because in EOG is positive, okay, rest everything is mixed, okay, there's something, but then here there's a lot of activity. When you have EOG में activity, okay, then it's going to be REM, okay. Sleep central K complex is 12 to 14 hertz is important. Next is changes. Elderly में you have less of REM, okay. So in elderly you have less of REM, you have decreased NC, increased sleep latency, okay. This is very well explained in actually you know this even I couldn't understand that well, but then sleep latency is basically it stays constant kind. Okay, so decrease N3, increase early awakenings. Okay, so decrease REM, decrease N3, increase early awakening because obviously REM is getting down, and increase sleep latency. And changes in depression, what happens? Just the opposite. Okay, increase REM sleep time, decrease REM latency, decrease N3. Okay, N3 is decreased in both. Okay, N3 is decreased in both repeated awakening and awakening, early morning awakening, terminal insomnia, all this we have, okay. So and in case of narcolepsy this is decreased REM latency, okay. So decreased REM latency in case of narcolepsy, decreased REM latency in case of depression, okay, and decreased REM, okay, increased sleep latency in case of elderly, okay. So elderly they have more of awakening, okay, increased sleep latency, मतलब सोने में टाइम लगता है, ठीक है. And decreased N3, decreased REM, okay, increased REM in case of depression, increased REM, decreased REM का latency, okay. This will go opposite, okay. So I think that is more or less done. And alcohol, benzodiazepine, these are very important. Decrease REM, okay. So decrease REM and N3, decrease REM and N3, where all we'll get decrease in REM and N3, we'll get alcohol, benzodiazepines, barbiturates, elderly, and even depression and narcolepsy, ठीक है, तो all of it, okay. And then even in non-epinephrine we'll have decrease REM, and obviously benzodiazepines useful for night terrors and sleepwalking. Remember night terrors, okay. P what was it, P and flea in N3, P and flea in N3 is sleepwalking, flea was sleepwalking, okay. terror you'll start sleepwalking and you'll wet your bed also. Okay, so this is done. Oh, okay, so this was like I just put all the stuff here itself. Okay, we'll just take the this thing. They go high frequency, low amplitude. Oh god, this. Okay, so they oh, okay, so beta is basically high frequency, low amplitude. Okay, so this is more important. Okay, high frequency, see, high frequency here, high frequency, low amplitude, and in deep sleep you have very high amplitude but very low frequency in case of REM sleep. Okay, and here ma'am had given a question ki alpha block phenomenon is seen in, or desynchronization is seen in sensory stimulation. Okay, and obviously K complexes and all this is easy. Okay, beta waves, parieto occipital. Okay, there only I had this thing and kaise this thing, and the muscle tone resting stage, increase sympathetic, decrease sympathetic, decide muscle tone reflexes intact. Obviously REM में this is very important, resting stage and NREM is decrease in sympathetic, muscle tone and reflexes are intact, and here you have pulsatile. Okay, increase GH and GnRH. Okay, but here in REM, what happens? Increase sympathetic, increase heart rate, increase BP, increase metabolic rate, increase temperature. Everything is increased. Okay, REM में everything is increased. We saw also. Okay, muscle tone is lost while penile tumescence and this thing you basically have. Okay, sleep cycle में N1 5%, N2 45%, N3 25%, and REM is going to be 25%. Okay, and how does each stage look? So alpha activity, beta, theta. Okay, stage 1 of sleep, obviously theta. Bats can't drink blood, bats can drink blood. Okay, and this and delta activity and this thing. Now this part is very important. Okay, that in which stage you'll have increased sympathetic, increased heart rate, increased BP, increased metabolic rate, increased temperature, but muscle tone is lost. Okay, in fact EOG is also increased in case of REM, but in case of non-REM everything is opposite. Okay, there'll be decreased sympathetic, it will be resting stage, but muscle tone and reflexes will be intact, and there will be more of pulsatile GnRH. Okay, so this loss of muscle tone important. Okay, that loss of muscle tone happens in this. Okay, rest everything is increased. There's ocular movement, there's increased BP, increased vein oxygen, increased ACTH, increased pulse, PP, and everything. Memory processing function also, this is important. Okay, next is PPRF. That PPRF is also important. Paramedian pontine reticular formation conjugate case. Okay, okay, next we have hypothalamus. Now hypothalamic nuclei, it will be best if, see, there are two ways to remember this. Okay, either you can see the pixelized stuff, or yeah, or we can just imagine a fridge. Okay, so if you imagine a fridge basically, so lateral side of the fridge, we have all the, like when we open the fridge, right? So when we open the fridge, so lateral side of the fridge, I mean we can this thing. Okay, see, lateral side of the fridge there's no food. Okay, so basically that's why it's, I mean we keep all the water there, right? So that's why there is hunger and hunger everywhere. Okay, now medial side of the fridge is all the food basically is kept in the middle. Okay, so that's why it's satiety and stuff. Okay, that's why basically satiety. Okay, now what happens is when you open the fridge, okay, then you basically have, when you open the fridge then you have that cooling sensation, right? So because you have that cooling sensation, okay, when you open the fridge, so anteriorly it is always cold. Okay, in case of a fridge, so that is parasympathetic and cooling. Okay, and posteriorly when you go behind the fridge, basically you'll get that heating. Okay, and obviously heating comes from sympathetic, so sympathetic stimulation. Obviously suprachiasmatic nucleus is going to be circadian rhythm, and supraoptic and paraventricular nuclei uh, that synthesizes ADH and oxytocin. That is fine. Next is preoptic nucleus, is obviously thermoregulation. Preoptic is thermoregulation, sexual behavior, and GnRH. Okay, so these mnemonics are not really needed. Okay, another Now, important points for each, like you can have this thing. Now, lateral nucleus was hunger, right? So if there's destruction, obviously you get anorexia. Okay, and hunger is always stimulated by what? Ghrelin. Okay, ghrelin is, it sounds also like khate raho kind of. Okay, keep eating, ghrelin. Okay, and leptin is inhibited by leptin, because obviously leptin is a satiety hormone. Okay, and ventromedial is craniopharyngioma. Okay, so that's why in craniopharyngioma you get hyperphagia, because ventromedial is for satiety and it hyperphagia and stimulated by leptin. Okay, obviously leptin is for satiety. Okay, next is another this thing, this part. Okay, preoptic nucleus. Okay, so this is very important. Failure of GnRH producing neurons. Okay, so failure of GnRH producing neurons to migrate from the olfactory pit. Okay, so that's what you have, anosmia along with this. Okay, Kalman syndrome mein we have not only everything is low in Kalman syndrome. This came as a match the following also, I think. Everything is low in Kalman syndrome because GnRH is not being produced. Why? Because failure of all neurons to migrate from the olfactory pit. Okay, so we'll have anosmia along with low LH, low FSH, low estrogen, low progesterone, everything low. Okay, in case of Kalman syndrome, this is important. Next, this is neurophysin, the other one that is going to carry from ADH from the hypothalamus to the posterior pituitary. Okay, so that is done. Next is here, obviously thirst, water balance, controlling adipo, hyper, neurohypothesis. This is not this thing. Inputs areas not protected by blood-brain barrier. Everything what was not protected was soap. Remember soap. Okay. S to even I'm getting confused. O is OVLT, area postrema. Okay, and A was S. S was what? Okay, again go back. Oh God. Okay. It was something. Yeah, it was this thing. Subfornicel. Yeah. Okay. Don't no need to go back. Okay, it is subfornicel. Okay. Next is thalamus. So these are actually very nicely. The pixelized images are very nice for this. Okay. Next is we have ventroposterolateral nucleus, and okay, I'll I'll come back to this later after dinner. Okay. Again, we'll have another session after dinner, and we'll try and finish neuro today.